So now let's go to the demonstration itself, but I need to first of all just explain what the device is that we're going to use. So to measure arterial pressure really most accurately, you'd need to put a catheter into the artery. Now that's not very practical, but you can actually get a pretty accurate representation of it by using this non-invasive technique using the Finapres device, very expensive device which we are using today. So the principle is as follows. You can't see it from where you are, but if you were looking at it, you'd see a little cuff around Jad's finger here, connected to a tube, and this device here. If you actually looked at this little cuff, you'd see within it these two little optical sensors. And then the principle of the technique is explained here. By the way, I'll give you these slides later. I'll put them up on the web later. But the principle of the technique of the method is as follows, that you've got the cuff around the finger, as you can see, and that cuff can be inflated by a pump. And the pressure in the cuff is measured continuously and displayed on the computer. But the point is that the sensors here, they respond to changes in the volume of the finger. It causes a slight change in the coloration, and that's sensed by this transducer. And so when the pressure goes up, this triggers this servo controller, which then increases the pressure in the cuff in such a way, it's a very rapid negative feedback system, in such a way as to maintain a constant volume of the finger. In other words, to do that, the pressure in the cuff must be equal to the pressure within the artery. And so that pressure that we're measuring is a very, I think, rather accurate surrogate for arterial pressure. And I think that's, so that's the principle of the operation as explained here. If the arterial pressure goes up, that's sensed, servo controller pumps it up, increases the cuff pressure and reduces the transmural pressure to zero. In other words, the cuff pressure is regulated so that it is equal, in effect, to the arterial pressure. Now I think we can go to the actual recording. Well, that looks terrific. Projecting now. Okay, so this is happening now. So what we're looking at on the top trace is finger arterial pressure, and you'll notice, incidentally, that even though Jad's not doing anything, pressure is not absolutely constant. This is normal. The trace in blue here is the computer calculates the mean arterial pressure beat by beat. It does this by taking the formula diastolic pressure plus 1/3 of the pulse pressure, which effectively gives you the mean arterial pressure, which is running beautifully at around 80 to 90. By the way, you notice those rhythmic fluctuations in pressure, and associated with, down here, rhythmic fluctuations in heart rate as well. Now, can I just stop this for a sec, or can I just do it? I just want to get, say, 5 seconds of arterial pressure just on its own, so we can just so we can have a look at the waveform. So that's really nice recording. Now you can see that looks pretty similar to the pressure I showed you in the previous slide. This is finger pressure. It's not that different from radial pressure. But the thing that really stands out is you've got a pretty rapid increase in pressure. If we were measuring aortic pressure simultaneously, we'd see a smaller pulse pressure. But the thing that is really quite characteristic about peripheral arterial pressure is this second, you can see a second peak there, and you think, well, you know, what's all that about? If you're measuring pressure in the aorta, you would not see it. I don't want to make a big deal of it, but it's so obvious I need to explain what it is. It's actually a reflected wave, because the pulse pressure is generated by the action of the heart, and a pulse travels from the aorta down the arterial system, down the system of tubes, and at the end it hits a resistance, which is due to the resistance vessels, the arterioles. And there's a partial reflection of that pressure wave. That's distinct from flow, of course. Flow doesn't go backwards, but the pressure wave does go backwards. And so when you're close to the periphery, the side of resistance, you actually often, nearly always, see a reflected wave there. So that's all that is. All right, so I think we can just go back to the normal recording. And we're going to do just a couple of simple manoeuvres. Just get a little bit of control recording, and when you're ready, Jad, could I get you to take, say, 4 or 5 slow, deep breaths, so roughly, one breath every 10 seconds. Nice, slow and deep when you're ready, and we'll see what happens. Okay, I think you can probably just stop that recording.
Yep.
Can we just change the time scale so we can just compress that a little bit? Yeah, that's great. So I think that's clear enough there. You can easily see what's happening. That this is, by exaggerating the breathing pattern, we've exaggerated those swings in pressure that we could see anyway beforehand, but they're now larger. And also you can see that the heart rate changes. Actually, we could probably change the scale slightly on the heart rate, so it's a bit more obvious. Maybe auto scale will do it. Yeah, that's okay. So now, all right, that's great. So now you can see more clearly the changes in heart rate. And by the way, notice how large these changes are. First of all, the changes in arterial pressure, mean arterial pressure, you can see on the scale here, is about 20 millimetres of mercury. And the changes in heart rate are about 20 beats per minute. I think in the previous demonstration, Sharon mentioned respiratory sinus arrhythmia, I believe. So this is what this is, as you now know. I'd like to talk a little bit about the reasons why pressure does change with breathing. And from that, I think I'll maybe go back to the slides if I can. Okay, that's terrific. Thanks. Good. So let me just show you what happened. So this is another recording that I made another time. But the difference here is that we actually measured breathing at the same time. So you can... Okay, so this is a similar type of recording and with similar changes in pressure and heart rate that you saw before. But I've also measured breathing. So inspiration is up and expiration is down. And so this gives us some... indicates the relationship between breathing and the subsequent heart rate changes. So what's going on? Well, let's talk about pressure first of all. Clearly that shows big variations with breathing. What's the underlying mechanism? Well, when you breathe in, a number of things happen. Firstly, on the mechanical side, on the right-hand side, inspiration, of course, is due to a decrease in intrathoracic pressure. That's what causes air to go into the lungs. But that decrease in pressure is transmitted to the heart, and in particular the veins in the atria, which are thin-walled vessels. So the pressure in the right atrium and in the central veins goes down. Central venous pressure goes down, and that actually means now that there's an acceleration of venous return back to the heart, because there's a greater difference in pressure between the pressure in the legs and the arms outside the thorax and the central venous pressure. Flow, of course, depends upon pressure gradient. You increase that pressure gradient, flow goes up, central venous return goes up, and the heart fills to a greater degree. And now Starling's law of the heart comes into play, whereby which describes the increase in stroke volume that occurs when the filling of the heart increases. Stroke volume goes up, and therefore the cardiac output goes up, and that increase in cardiac output will cause an increase in arterial pressure. There's another aspect to this, and you noticed also that there was an increase in heart rate associated with inspiration. And that's due to a different explanation, because heart rate is controlled by the sinoatrial node. It's not affected to any significant extent by any mechanical changes in pressure in the heart. It's controlled by the action of the autonomic nerves that innervate the sinoatrial node, that is the cardiac vagus and the cardiac sympathetic nerves. And there is this very interesting reflex which arises from receptors within the lungs, pulmonary stretch receptors. Lungs are full of these receptors. They fire when the lungs expand and fire more when you increase the magnitude of inspiration. And then via the afferent fibres back to the lower brainstem, this causes the reflex increase in heart rate, mainly by inhibiting the vagus nerve, which innervates the heart. And that increase in heart rate also tends to contribute to the increase in cardiac output associated with inspiration, and thus the increase in arterial pressure. So here's the same slide again, and just have a look at the time relationship. So this line here shows the beginning of the period of inspiration. There's a little bit of a delay before the heart rate goes up. It's only a couple of seconds. And this is what you would expect for a reflex that's neurally mediated. There's a longer delay until the arterial pressure starts to go up. And the explanation for this is that, well, the increase in cardiac output firstly occurs on the right side of the heart. So the accelerated venous return to the right side of the heart, right atrium, right ventricle, increased flow through the pulmonary artery, through the lungs back to the left atrium, increased flow to the left atrium, increased filling of the left ventricle, increased output. And that takes a few seconds for blood to flow through the pulmonary system, and hence that delay. So we can conclude then that, I'll leave that for later, we can conclude then that the mechanical effects and reflex effects predominantly cause the changes in pressure associated with breathing, which are not insignificant. Now, the next manoeuvre that we'd like to do, pretty simple one, is just a change in posture. So I'm going to ask Jade, if you wouldn't mind, would you be able to just sort of squat down on the floor? I would have difficulty in doing this, but it'd be easier for you. And so we're just going to keep recording for a bit, take a control recording. And yeah. And then after a little while, we'll just wait another few seconds. All I'm going to ask Jade to do is to stand up and just remain standing. So this is a pretty standard manoeuvre that we would do dozens of times every day. And so when you're ready, Jade, just stand up and just stay standing, just relax, and we'll see what happens. Keep recording for a bit. Just get, say, about 30 seconds of recording, and then we'll look at that. Can I get that back on my screen, so if that's okay? We've still got the other one up here, that's all right. Great. Well, this is another beautiful recording. Just wait until things settle down, and then we're fine, and so you can just sit down again if you like. And so we'll just stop that there. Thanks very much. So what's happened is that at this point, Jade stood up, and after a few seconds, a slight initial rise, but then a fall in pressure. But I want to draw your attention to the fact that the heart rate increased. But note that the increase in heart rate occurred before the pressure fell. Let me now just show you another example of the same thing, and then we'll talk about it. So I'll need to just go back, back to my slides. Pretty much the same thing that he recorded the other day. I'm just replaying this slightly greater speed, but you'll see very much the same sort of pattern. A little bit of a blip at the start, then the pressure falls, and that's it. And so the fall in pressure, in this case, and I think it was very similar in the example we've just seen, the maximum fall in pressure is in this case, from about 100 down to 60, a 40 millimetre of mercury fall in pressure. And here's the rise in heart rate. And again, not quite as obvious as before, but it does start to increase slightly before the pressure falls. So that gives us some clue as to what mechanisms might be responsible for this. So now I'd like to talk about those mechanisms. And some of this looks simple, but it's actually much more complex than you might think. Now, there are two ways in which you can change your posture. The usual way is, as we've just seen, you know, you're sitting down and you stand up, or you're squatting and you stand up, or you're lying down and you jump up and you stand up and you use your muscles to do that. So we call that standing up, and that's actually from the textbook. And what we've seen is very similar to the textbook example. Initial slight rise and a fall in pressure, then it recovers within probably 20 seconds at least, or less I should say, and the heart rate goes up starting before the fall in pressure. If we were measuring the stroke volume and cardiac output, which is a bit tricky, but if we were, you'd actually see, surprisingly, a bit of an increase in cardiac output during the time that the pressure is falling. What that actually means then is that the total peripheral resistance is actually falling at that time. It's not maybe what you would expect, because remember, mean arterial pressure equals cardiac output times total peripheral resistance. If mean arterial pressure is going down and cardiac output is going up, then mean arterial pressure divided by cardiac output is going down a lot, and indeed that's what happens. And here is the sequence of events. So we saw Jad stood up, and this is what happens. He's using his leg and abdominal muscles to stand up, and this has a number of effects. Firstly, mechanically, he's compressing the veins in his legs, and that has the effect when you compress the veins, and just because the veins run within the skeletal muscles, contracting your skeletal muscles compresses the veins, and thus that tends to accelerate the rate of venous return back to the heart. Reason being that there are valves in the veins which allow flow in only one direction. It's actually called the skeletal muscle pump, and it contributes to the increase in venous return during dynamic exercise. When you compress the veins, then the venous return is increased. And so transiently, at least, this is only really going to occur in the first few seconds, the venous return goes up, the atrial pressure goes up, and those receptors in the atria, which reduce their firing rate during passive tilting, under these circumstances increase their firing rate. And instead of causing a reflex increase in sympathetic activity, it's the opposite effect. It's a reflex inhibition of sympathetic activity. So that's one component. One of the effects of that is to contribute to vasodilation in the leg muscles. But in addition, contraction of muscles in itself, the metabolic changes associated with that, also directly affect the arterioles, the resistance vessels in the skeletal muscles. So those arterioles dilate, leading to a vasodilation in leg muscles, and thus a fall, and that contributes to a fall in total peripheral resistance. And in addition to that, there's an increase in heart rate, as I've pointed out, and it was an immediate increase in heart rate. So it cannot be explained as some sort of secondary effect of changes in pressure or anything else. It's actually due to a feed-forward mechanism. It's not a reflex, it's central command. Really important to understand that a lot of cardiovascular regulation is not just feedback regulation like the baroreceptor reflex that I've just described, but it's feed-forward. So when you start exercising, your blood pressure, heart rate starts to go up straight away. At least half of that is due to central command, originating in that case from the motor cortex. So there is a central command. In addition, contributing to that, some feedback from muscle receptors activated by contraction of skeletal muscles, tending to also increase cardiac output. But the overall effect, at least initially over those first seconds, even though the cardiac output goes up a bit, as you can see, that there is a very large decrease in total peripheral resistance, so that overall mean arterial pressure is cardiac output times total peripheral resistance, but the fall in total peripheral resistance proportionally is greater. The mean arterial pressure tends to fall. But then, this is initially, after about 10 seconds or so, then other factors come into play. And one is that, as I said before, even though there may be a transient increase in venous return, ultimately there is a shift, as I've said, of the total venous volume to the lower parts of the body. So after that initial first 10 seconds, the venous return now decreases because of the shift of venous volume from the thorax to the lower part of the body. And that will tend to, the blood pressure, of course, is already reduced, and that would tend to reduce it a little further. This then triggers, as a secondary effect, the baroreceptors and atrial receptors that I described previously, which are involved in passive tilting, and that then tends to restore arterial pressure. And I use this example. I know it's complicated, but really what I want to bring home to you is just how important the combination of the number of mechanisms that are involved in regulating blood pressure, or even during these daily simple manoeuvres. Central command, feedback from reflexes, and the mechanical effects of respiration and skeletal muscle contraction all contribute. But ultimately, it all works beautifully, because after that initial transient change, the arterial pressure is restored. You might even notice here, and I think we saw it in the in the demonstration, the pressure is actually greater when you're standing up than when you're lying down very often. And that also physiologically is advantageous, because under circumstances where a person may want to escape or flight or fright or whatever, increased pressure obviously is an advantage.